Now we will be studying about the histology of the cervix. As we previously have discussed that cervix is having a superficial squamous cell layer which has the intermediate cell, parabasal cells, basal cells and the superficial squamous cell layer. Uh, while the endocervical cells contains the columnar cell layer, and then we have endometrial cell which is present in the uterine cavity. So coming to superficial squamous cell layer, these cells are polygonal in shape. The cytoplasmic keratohyalin granules are present in the cells, and these have condensed of the pycnotic nuclei. The cross-sectional area is approximately 10 micrometers, and they are light brown in color due to the presence of glycogen. Now for intermediate cell layer, they all have the same shape, but as we move from down to upward, the cell size increases. So there is slightly lesser size in this intermediate cell. They are also polygonal in shape. The nuclei possess fine granular chromatin with a longitudinal groove. So the nucleus is having fine granular chromatin with a longitudinal groove, just like kidney beans. The cross-sectional area of the nucleus is approximately 35 micrometer square and is generally an internal reference for size comparison. So this cell is used to compare with the size of the other cells. So this is important. Intermediate cell is used for reference for size comparison. Then coming to parabasal cell, these parabasal cells have a bigger nuclei as already discussed, and this nuclei is having a fine chromatin and contains a cross-sectional area of 50 micrometer square. So the smallest nuclei is present in the superficial squamous cells and intermediate cells in the basal and the parabasal cells. The cytoplasm of these parabasal cells is dense and heaped up, resembling a hill with a sloping sides. Now coming to endocervical cells, nucleus is finely granular and evenly distributed chromatin pattern with small nucleoli is seen. The cytoplasm is diffusely vacuolated or granular. Cells exhibit polarity with nuclei at one end of the cytoplasm and mucus is present at the another end. So these columnar cells are present. The nuclei is basal in location and the mucin is filled on the opposite end. And this pattern is giving a honeycomb or a side picket fence appearance to the endocervical cells. Endometrial cells are smaller than the endocervical cells and they have high nuclear to cytoplasmic ratio. The NC ratio tends to be dense and heterogeneous. The nuclear chromatin is dense and heterogeneous. So the nucleus of endometrial cells is heterogeneous and dense, while nucleoli is generally not prominent. So if the nuclei is prominent, it indicates malignancy. The cytoplasm is also scanty, and the exfoliated endometrial stromal cells, these are dense aggregates which are surrounding the layer of the glandular epithelium, also known as the exodus balls, because of its presence at the end of the menstrual flow. So after menstrual flow, these exodus balls can be seen in the discharge because of the presence of exfoliated. So these exfoliated endometrial cells are surrounded by the glandular epithelium, making a exodus ball appearance. So coming to the neoplastic changes of a squamous cell, we already discussed about the Bethesda system of classification. Pre-malignant squamous lesions are given 4 appearances based on the level of malignancy. They can be ascus, ASCH, LCIL, HCIL and a squamous cell carcinoma. Then there is one finding which can be seen, that is NILM. NILM is negative for intraepithelial lesion of malignancy. Specimens with no epithelial abnormality are classified as NILM. Now what is ascus? Ascus is atypical squamous cells of undetermined significance in which the nuclei are approximately 2.5 to 3 times the area of the nucleus of a normal intermediate squamous cell, which has a diameter of approximately which have an area of approximately 35 millimeters square. So the nuclei is increased in size more than 2.5 to 3 times. It is increased in size as compared to the intermediate squamous cell, and because nuclear size is more, hence NC ratio is increased and the minimal nuclear hyperchromasia is seen. Then what is coilocytosis? Coilocytosis is a cytoplasmic halo which is present around the nucleus, and it is due to HPV cytopathic effect that leads to incomplete coilocytosis, including poorly defined cytoplasmic halos or the cytoplasmic vacuole. So in this squamous cells, which is pinkish in color, NC ratio is increased, but there is halo which is present around the nucleolus, known as the coilocytosis. So two conditions can arise. First, we can have a woman with low grade lesions, that is ascus or alcil, with a age of 25 to 29 years. So what will you do in a female if she comes at this age group and with these findings, as these are the low grade lesions? So what we will do if the patient is non compliant? So it is dependent on the compliancy of the patient. So if patient is non compliant, means he or she, means she is not going to visit you after this visit. So what we will do, we will advise her for colposcopy or via plus minus biopsy. So this can be done. And if she is a compliant patient, then we can repeat her cytology after 6 months, means twice annually, means every 6 months we will repeat her cytology. And if on the repeat cytology her report came out to be NILM, then we will repeat the cytology, or the screening is done after every 3 years, and we will return to the routine age specific screening as advised by the ASCCP. Now, if on repeat cytology ascus or more than ascus is present, then directly we have to go for colposcopic biopsy, and if the colposcopic biopsy is normal, then we will repeat. So here we are repeating the cytology after 3 years if findings are normal. But if findings are abnormal and colposcopic and biopsy is also normal, then we will repeat the cytology at 1 year. And if they are abnormal, then we will follow the FOXY CIN management GCPR rules. We will discuss further. Now, if the same findings are present in a female with 30 to 64 years of age, so what will you do? So the next step is, if patient is non-compliant, then directly do colposcopic biopsy, and if the patient is compliant, then either we can go for the HPV testing, and if HPV is negative, then 5-year follow-up is done. So here we have done a co-testing. Co-testing means pap smear report plus HPV DNA testing. So co-testing is done. So the monitoring advised is after 5 years, either through HPV DNA testing or a co-testing. And if HPV is positive, means ascus is present and HPV is also present, then we will go for colposcopic directed biopsy, and if colposcopy is normal, then co-testing is done at 1 year. So after colposcopy we have to go for 1 year screening, and if HPV is negative, then 5 year, and if cytology is negative, then 3 years. And if colposcopic biopsy is negative, abnormal, then we will directly go for this. So this and this we have to discuss further. Now, if there is not convenience of doing HPV DNA testing, means patient's affordability is not there, so what will we do? We will repeat her cytology at 1 year. Here we are repeating her cytology at 2 years, matlab twice annually we are repeating, but here we are going to do it at 1 year. So if it is negative, then 3 years routine screening is recommended, and if the cytology is telling about the low grade lesions, then like this we will go for the colposcopic directed biopsy, and if it is normal, then again we have to monitor her for 1 year. And if it is abnormal, then same management like this. And if high grade lesions like H or HCl are present, then monitoring is going to get differ further. So what will you get in ASCH? ASCH is atypical squamous cell of high grade significance, and high grade lesions cannot be ruled out. So in this, cells usually occur in a single or small groups of less than 10 cells. So here the cells are lesser in number, and usually they are less than 10 cells. Cells are the size of a metaplastic cell, so the cell size is increased, and nuclei is also increased about 1.5 to 2.5 times larger than normal. So the NC ratio is increased and maybe approximate that of HSIL. Now, what is ALCIL? ALCIL is low grade squamous intraepithelial lesion in which the overall cell size is large, with reasonably abundant, mature, well-defined cytoplasm. Nuclear enlargement is seen more than 3 times the area of the normal intermediate nuclei, but slightly increased. So NC ratio is not more increased, it is slightly increased. Nuclei can be 2 or multinucleated. and the nucleoli is generally absent or inconspicuous if present. And coelocytosis is also present, which is a perinuclear cavitation consisting of a broad, sharply delineated, clear perinuclear zone, and a peripheral rim of densely stained cytoplasm is a characteristic of a viral cytopathic effect. So this is a enlarged and darker nuclei with coarse chromatin and irregular nuclear contour can be seen. These are the alcyl lesions, and this is an unremarkable intermediate cell which is used for comparison. So how will you manage a lesion which is HCl in a woman aged 30 to 64 years? So if a woman with HCl on her pap smear report comes to you in an age group of 30 to 64 years, so just like ASCUS, we will do her HPV DNA testing, and if HPV DNA testing is negative, then co-testing is advised at 1 year. In ASCUS, co-testing is advised every 5 years, but if negative test is there in HCl, then co-testing is done at 1 year of age. HPV DNA test, if positive, then directly go for colposcopic directive biopsy and manage as per FOXY GCPR guidelines. Now, if after co-testing cytology is normal and HPV is negative, then this 1 year changes to 3 years, and the cytology normal, HPV negative, then 5 years. So 1, 3 and 5 if everything is coming normal. While if HPV DNA testing is co-testing is done after 1 year and the cytology is ASCUS or HPV positive. If she is HPV positive or ASCUS, even after co-testing at 3 years, then directly go for colposcopic directed biopsy and manage as per FOXY GCPR guidelines. Also, if patient is non-compliant, then you can directly, in alcyl lesions, you can directly go for colposcopic directed biopsy, or if patient is non-compliant, then via or colposcopic directed biopsy along with ablative therapy can also be given for management of the pre-invasive lesions of the cervix. Now, what is HCl? HCl are smaller and shows lesser cytoplasmic maturity than the cells of alcyl. Syncytial aggregates of dysplastic cells may result in hyperchromatic crowded groups. So these crowded groups can appear. You can see that. So these are the syncytial aggregates. HCl cells जो होते हैं वो छोटे होते हैं as compared to alcyl cells. High grade lesions often contain quite small basal type cells. The degree of nuclear enlargement is more variable than that in alcyl. A marked increase in the nuclear cytoplasmic ratio can also be seen. So if a female with ASCH or HCl lesion is coming to you in an age group of more than 30 years, so 30 to 64 years, what will you do? So these are high grade lesions. So there is no role of HPV DNA testing here. We will directly go for colposcopic directed biopsy and the endocervical assessment. Adequate transformation zone if zone 1, that is transformation zone 1 or 2 is present, and if in this the CIN less than CIN1 lesion is present, so we will either we can go for co-testing at 1 year, and diagnostic excision excision procedures can also be performed. But if CIN is 2 or 3, then excision or ablation of the transformation zone is definitely to be done. Now, if colposcopic directed biopsy and the endocervical assessment is inadequate and transformation zone is not visible, then we cannot take endocervical sample. So here we will directly do diagnostic excision procedures and follow FOXY guidelines for the management of CIN. Now coming to squamous cell carcinoma, marked variation in cellular size and shape is typical. Caudate and spindle cells contain dense orangiophilic cytoplasm. So here typical caudate and spindle cells are present. Tadpole cells are also seen. Nuclei vary markedly in area. Nuclear membranes may be irregular and numerous. Dense opaque nuclei are often present, and nucleoli is important. So usually in usually nucleoli are absent, but if nucleoli is present, then it can indicate the presence of squamous cell carcinoma. Now, what are the neoplastic changes in the glandular cells? These can be atypical endocervical cells, endometrial cells, or the glandular cells, or atypical endocervical cells with neoplastic component, or glandular cells favor neoplastic component. Endocervical adenocarcinoma in situ is the another entity. Fourth one is adenocarcinoma. It could be endocervical or endometrial or extrauterine in origin, not otherwise specified. So what are atypical endocervical cells? These cells are basophilic in appearance. They occurs in sheets and stripes with some cell crowding, nuclear overlap, and pseudostratification. So the layer is single, but they appears as if they are stratified. So this is pseudostratification. Nuclear enlargement is 3 to 5 times of the normal, and mild nuclear hyperchromasia can be seen. Cytoplasm may be abundant, but the NC ratio is usually increased. Then atypical endocervical cells, which favor neoplastic changes. They also have pseudostratification, crowding, and overlap, and rosette formation or feathering can also be seen. So in this rosette formation, that is gland formation or feathering, is seen. Nuclei is enlarged and often elongated with some hyperchromasia. Coarse chromatin with heterogeneity is present if there is neoplastic changes, and cell borders are ill-defined. NC ratio is increased. Atypical endometrial cells, the cells usually occur in small groups, usually 5 to 10 cells per group, and they are the nuclei is slightly enlarged, mild hyperchromasia, and chromatin heterogeneity is seen. So these are the atypical endocervical cells, these cells favoring the neoplastic changes, and these are the atypical endometrial cells, and this is endocervical cells, endocervical adenocarcinoma in situ. So what is endocervical adenocarcinoma in situ, in which feathering is seen? So this is feathering. Hyperchromasia, perpendicular nuclear polarization, nuclear crowding is present, and rosette formation is also seen. Endocervical adenocarcinoma, you can see how much nuclei is getting big. So these are abundant abnormal cells, enlarged pleomorphic nuclei, demonstrate irregular chromatin distribution, chromatin clearing, and nuclear membrane irregularity is seen. And the nucleus is very large in size, which is known as a macronucleoli. The cytoplasm is usually finely vacuolated. So this is endocervical carcinoma. And atypical glandular cells, we have already seen ascus in squamous cells, but agus is eliminated to avoid confusion with ascus. AGCs can be present. These AGCs are atypical glandular cells. These are the percentage of cells associated with underlying high grade disease higher than ascus. Atypical epithelial cells, squamous versus glandular origin cannot be determined. So what will you do if your pap smear report is showing abnormal glandular cell with atypical endometrial cells? So the cytology report is showing atypical endometrial cells. So what we will do, we will take the endometrial sample, means endometrial and endocervical curettage is done and sent for endometrial pathology, and we will manage accordingly whatever the report is. And if there is no endometrial pathology found, then we do colposcopic directed biopsy and assess the cervix for any abnormality. So these are the different classification system used for cervical region based on histology and cytology. So natural history model, infection, precancer, and cancer. Then we divide it into histology based classification and the cytology based classification. So for histology based classification, we have dysplasia nomenclature, CIN nomenclature, and the last is lower anogenital squamous terminology. So this is last. Then cytology means it includes the Paniclow classification and the Bethesda system of classification. So based on histology can be negative. Dysplasia, it could be negative. Squamous atypia, mild, moderate, severe dysplasia means if CIN is characterized, then mild dysplasia is characterized as CIN1, moderate CIN2, and severe dysplasia is CIN3. Then carcinoma in situ and the carcinoma. CIN nomenclature negative, squamous atypia, CIN1, CIN2, CIN3, and carcinoma. For last nomenclature, we have LCIL and HCIL. So if CIN1 is present with P60 negative, then the histology is LCIL, and if CIN1 is present with P16 positivity, then HCIL, CIN2 with P16 negative LCIL, CIN2 P16 positive HCIL, and CIN3 whether it is P16 negative or P16 positive, it is always HSIL. And then we have carcinoma. Now coming to cytology grading, then Papineau classification, negative for grade 1, squamous atypia grade 2, mild, moderate, severe grade 3, grade 4, and grade 5. Then the Bethesda system of classification, NILM, or negative for interepithelial lesion of malignancy, ascus, LCIL, HCIL, and carcinoma. So P16 is important because P16 is a proliferation marker. Now looking at the summary. So if ascus lesion is there, so what will we do? We can either go for colposcopic directed biopsy if there is a patient who is non-compliant, and if HPV DNA testing is affordable, then we can directly do HPV DNA testing. If it is negative, then we will follow with co-testing for after 5 years, and if HPV DNA testing is positive, then we will manage it accordingly. Means we will do her colposcopic directed biopsy. And if patient is not having the availability of HPV DNA testing, then repeat cytology at 1 year can be done. And if the lesion is more than ASC, then manage accordingly. And if it is negative, then routine screening is recommended. For LCL, positive or no HPV DNA testing, directly go for either, you can directly go for colposcopy, and if HPV is negative, then co-testing or colposcopy can either be done. ASCH always go for colposcopy. HCL lesion management is LEAP, that is loop electrosurgical excision or colposcopy, and endocervical curettage. For AGCs, we do colposcopy, endocervical curettage, and endometrial sampling.